Hi, good afternoon, everyone. Thank you all for the opportunity to present. So yes, we will be talking about predictive models for hernia planning using CT imaging. I have no disclosures. So the ubiquitous CT scan, it is, I think, become really one of the most important tools that we have in assessing our patients in all of hernia surgery. It's available, it's reproducible, it really has become the standard of care. Like Sean mentioned, it's relatively inexpensive, and I think for most of us, it has really become an extension of our physical exam. So who gets a CT scan? Just about everyone. Primary umbilical hernia or inguinal hernia, and probably not. But honestly, a lot of our patients also already have CT scans when we see them, and we can use those to help assess our surgical planning. And they tell the truth, so that's why we like to use them. But what technique can we use? How do we decide between all of these options? You know, we recently interviewed for our fellowship, and one of the applicants asked, what do you think is the most important thing that you can teach your fellow? And I honestly think it's making these decisions. The technique is definitely important and something that we need to stress, but how to decide what technique to use, what optimization do you do or not do, or is this in your wheelhouse, or do you need to refer it somewhere else? And right now, I think most of the time we're using our surgeon gestalt, and that works a lot of the time. But if we have some data and some information, can we use it, and what can we predict? And there's a lot of models out there. I didn't get the memo from this morning with the PubMed search in the last thing, but the PubMed search for this is actually huge. There's tons of different models talking about emergent repairs. Can we close the fascia? Do we need a component separation? And are there complications? I'm gonna focus on the emergent repair and the fascial closure, as there's a session on complications a little bit later. So for emergent repair, the defect size matters. We know that. If you look at the, this is from the Danish Hernia Registry, and they showed that there is a much more likely chance of emergent repair in the width of 2 centimeters to 7 centimeters, which I think logically makes sense, right? A lot less hard to get anything stuck in there, and when it's much bigger, we think that things will move more freely. But is that as good as using different ratios? So you can also use the hernia neck ratio. And that basically, like showing here in the picture, is just measuring the neck, the defect size, and then the sac size. And if the hernia neck ratio is greater than 2.5, there's a 53 times increased chance of the patient will have a complication, and while you're waiting for your surgery. So I think that that's an important thing to look at while we're looking at our CTs. Again, if you look at this, you can see that you looked at primary hernias as well as all coming hernias, and they looked 2.4 and 2.5 as the cutoff for that ratio and needing an emergent repair. And if you really like math, you can use this extremely complex formula. I'm not sure how many of us are gonna do this when we have 30 patients in our clinic, but I think it's important to look in, and see. So this is the odds of the emergent repair ratio. And what it really is looking at is that angle, and that I think is what we can kind of see very quickly on the CT scan is, beware of the mushroom. The more that angle compresses, the more concerned that you kind of need to be. And they show that using this formula, that if the score is less than 5, you have a pretty unlikely chance that you're going to need to do an emergent repair, whereas if it's greater than 10, you have a 2.5 times increased odds of emergent repair. So can we predict when the fascia will close? When will we need a component separation? I think this is probably one of the most things that we really all want to know, both in open and minimally invasive surgery before we get in the operating room. What's our plan A? And of course, we always need a plan B and plan C. So defect width. Area, there's a few measurements we can look at. There's some volumetrics that we'll look at, and then there's a lot of different equations out there. So if we look just first at width, Dr. Augenstein's group in Carolina showed us this, that if the width is greater than 8.3 centimeters and the hernia defect size 164 centimeters, that you will likely need a component separation in order to get the anterior fascia closed. Then we can look at volumetrics. Now, volumetrics are hard because we don't always have access to them, and despite this looking like a fairly simple ratio to volume ratio, in order to to show that hernia sac volume and the abdominal cavity volume, you have to assume an ellipsoid and do about 4 slides of math that you are thankful that I hid the slides and I'm not showing them to you because they're not very exciting. But the reality is that if that ratio is less than 25%, you are going to be likely to be able to get your fascia closed without, again, this paper is focusing on pre-op pneumoperitoneum, but I think in general can be applied to getting that fascia closed, which is what we're all worried about. If you look at the other method, it's quite similar. The ratio is slightly different though. So the ratio that they're looking at with this method is the hernia volume over the entire peritoneal volume. And that peritoneal volume is the hernia volume added to the abdominal cavity volume. When they had fairly similar results, when you look at this ratio less than 20%, they had an almost 90% tension-free fascial closure rate. Whereas if it's greater than 20, you have only 12%. So it's a pretty good cutoff number where you can really show that they're going to have likely a difference. Then we get into some more math and more ratios. These are things that I think are a little easier for us to calculate, in our clinics on a daily basis and kind of to look at and see if they will affect our practice. So the hernia defect ratio is the same as the hernia defect percent, just described by a couple different people. And again, it's using that defect width and then the entire circumference of the abdominal wall. And we have 2 different groups that showed this, and they showed that as the HDR increases, your fascial closure rates decrease. There's no cutoff in these papers, so we can't really use a number to predict that because there just wasn't enough patients. But you could imagine, as you get on the drastic ends, that this may be helpful as you look at it. And then there's the component separation index. So again, something that you can fairly easily calculate. I think when you're looking at your CT scans, you look at that angle of diastasis, which you can see there drawing a line from the medial edges of the rectus down to the aorta and the midline. And you look at that ratio or that angle and you divide that by 360. And basically, they're showing all patients with component separations in this paper out of 2012, and this is a plastics paper, and it was mostly external oblique releases. But again, they did show that the 0.1 was the CSI if they were likely to be able to get the fascia closed versus 0.2 if they couldn't. And Carbonell replicated this in his paper, and he showed very similar numbers. So you're looking, again, that the fascial closure is, if you're getting to fascial closure, it's about 0.2 as far as a cutoff for using this CSI value to predict your ability to close the fascia. And then the Carbonell equation, which was, I think, the main topic of that paper, but they did also talk about the CSI. And so what they're doing here is, again, these are simple measurements that you can do kind of in your clinic. You're looking at the defect size and then the width of the rectus muscle. As Sean mentioned, there's a lot to, I think, look at with the rectus muscle. How thin is it? Does it look healthy? Does it not? But the width is one thing that we can, easily put into an equation. And if you look at these, these 2 hernias that are not terribly different in width, right? An 8 centimeter and a 9 centimeter hernia. But if you use his equation and add the 2 rectus and then divide it by the width, you get 1 on the left and 2 on the right, therefore predicting that you may need a component separation in one and not in the other. So again, they looked at this and they stratified it into different groups, and they were able to show that if the RDR was greater than 2, that you had only a 10% chance that you're going to need a component separation. So again, I think, not perfect, as none of these will be, but a fairly good accuracy with their predictive model to be able to tell you when you may need that. And I think for a lot of people, if you do a lot of TAR, this may not be super helpful because you'll make your decision in the operating room. But I think for those that are not doing that yet or have to decide if they want to send the patient somewhere else, that's where these things, I think, can be of great use. But we're doing everything robotically now, right? So do these numbers apply? Is it different? And I think, it is. And they use the exact same formula, the exact same measurements. And what they showed was that you need a higher ratio in order to be able to appropriately predict the ability to to not need the component separation. So in this study, they stratified again, and they showed that if it was greater than 2.5, that their percent of needing a TAR was only 7. And again, this paper was a little bit later on, so almost, I believe, all the cases in this one were TAR, whereas previously they had a stratified between the two. But we really cannot talk about predictive models without talking about AI. And AI is coming into our lives in medicine. It's coming into our lives outside of medicine, and we really can't we can't move forward, I think, without talking about it. I don't think it's necessarily at our fingertips to apply to our practice currently, but it is going to be in the future. So there's been a lot of work with deep learning, and deep learning is really a subset of AI where it takes information, and it really works well nowadays because we have so much increase in our computer power. And the computer is able to look at things and teach itself what is right or wrong. So you have a yes-no algorithm, and it works well when you have a lot of data. So you give it the data, it is able to teach itself, well, this is yes and this is no, and then when it goes back, it can learn from itself and actually predict those things. So again, it extracts those features on a positive and negative, and then is able to learn from those sets. So CTs are there, we have them, our patients have had them. So I think that the ability to try to use them in order to figure this out is something that is going to be of great benefit in the future. Again, Dr. Augenstein, Dr. Henneford's group looked at this, and they were able to show that using a deep learning model, both to teach itself and then to validate it, that they were able to predict surgical complexity, which they defined by needing a component separation, as well as SSI. The pulmonary failure rates were quite low, so it did not have enough power in order to predict that. But I think that, these are, again, things that maybe won't change what we do. Maybe they will. Will they change our referral patterns? I think it's all very exciting and interesting of what will come next. And maybe someday we can just ask Alexa if we need to do a TAR, and she'll be able to tell us ahead of time. I don't know. But it's coming. More information is coming. The ability to do really complex things with computers and AI is going to be the future. And I think how we are going to apply it to our everyday lives is really the question. And how can we get it at the tip of our fingers, right? Maybe there will be an app where we just, take a QR code, a nice quick screen of the CT scan, and it tells us exactly what we need to do. I think there'll always be an art to medicine, but being able to predict some of these things, or at least have informed conversations with your patients and really augment our current consent process is really exciting. So thank you guys so much for the talk. And I do want to invite all of our women hernia surgeons to the Limitless Leaders Summit next year in Boston. Thank you.